Good morning, dear colleagues. We're going with the next presentation for the radial and tibial approach, radial brachial and tibial approach combination for the peripheral artery disease of the superficial and popliteal below the knee occlusion and stenosis. The axis for peripheral artery intervention, it's common femoral artery, brachial artery, radial artery, popliteal artery, and tibial artery. We can put here and axillary subclavian artery in some case, and carotid artery. We have experience and with carotid artery for the some peripheral intervention, but for the other part of the peripheral intervention, not for the SFA and popliteal artery. The femoral approach is the very good approach for the peripheral artery disease because it can be used for the contralateral procedure, for the iliac intervention, femoral tibial intervention, ipsilateral popliteal and tibial intervention. It's very close to the lesion, and this gives us more and more support for the calcificate and for more support for the device crossing from the lesion. Use of closure device, the femoral approach is only with the most closure device dedicated for this approach. We can use all of them for the angioceal, manta, prostyle, everything is dedicated for the femoral approach. And we use the same device for the other approach, like the brachial, but it's off-label. For carotid, it's still off-label using the closure device. But what is situation compared to radial and femoral approach? The femoral approach is still with more complication compared with the radial axis. Brachial approach, in the last year, the brachial approach returned for endovascular procedure, total endovascular. It's more convention for the operator, using for large device compared to the radial, more complication compared to the radial, but the complication compared with the femoral approach, it's no difference. We have publication about this compared radial and brachial approach on 2,000 patients, and the result it's the brachial approach, it's safety for the use for the peripheral intervention. We use for coronary intervention. The radial approach, the transradial artery axis has transformed for coronary intervention. In the Bulgaria, it's the must use it axis for the coronary intervention, and we use the same radial axis for the carotid intervention. It's reduced bleeding and axis site complication, improvement patient comfort. It's not necessary to stay in the bed for a long time. Short time for the ambulation, stay in the hospital after procedure, reduce hospital stay, and potential reduce the mortality rate. Popliteal approach, retrograde axis, but it's more not comfort for the operator, for the patient, compared to the tibial, more complication compared to the tibial axis, and use it only for the femoral and iliac segment. It not can be used for the tibial artery lesion. Tibial approach, using always for the retrograde axis, reduce bleeding and axis site complication, improvement patient comfort. It's short time to ambulation after the procedure, reduced light of the hospital state. It can be used for the tibial, popliteal, femoral, and iliac segment. Our experience with the tibial approach, we see for the last 5 years, we have around 2,000 patients with intervention of the femoral artery, superior femoral artery, and we see on the second column that the number of the patient with tibial approach, little more from 10% average using the tibial approach, and last 2 years the percent go up, and for this year, only third patient going with the tibial approach for the recanalization. You can see here in the graphic our experience with the tibial approach. Successful, it's 97%, 98%. In 3 patients, we don't have successful about the spasm of the artery. In 2 patients, access it's not successful because we not can crossing from the proximal occlusion of the tibial artery who need to intervention. Complication, the rate of complication is so low. 2 patients with hematome, 1 patient with asymptomatic tibial occlusion. Clinical case, I want to show one patient with risk factors for atherosclerosis, hypertension, dyslipidemia, with coronary artery disease after stent implantation of right coronary artery, present with claudication on 100, 200 meters, date from Doppler ultrasound, significant stenosis of external iliac artery, and SFA, occlusion of distal part of SFA and popliteal artery. This is the angio. We see the stenosis of the iliac and femoral artery, occlusion in the segment, the date from the Doppler we see in angio, and collateral flow in the tibial posterior artery. This is the procedure after predilatation of the stenosis of the iliac and SFA. We implant the stent VZ Pro balloon expandable stent of the external iliac artery and 1 stent of the ostial proximal segment of SFA. And this is after stent implantation result on this treatment segment, and we see the occlusion of the distal SFA and popliteal artery. We not can crossing from the proximal part of the occlusion. For that, we're going to use the tibial artery access. We see the puncture of the tibial artery on the angio, and placement the wire. This is the crossing with Super J catheter 0.35 and supported catheter. Crossing from the in the lesion, and after that predilatation with balloon, long balloon, on 20 millimeters. Sheetless, we see the result after dilatation. We see still have stenosis and dissection of the popliteal part of the lesion. After that, sheetless, we implanted superior stent of the popliteal artery, stent dedicated for indicate for the popliteal artery. Final result for the distal AFS, and final result for the popliteal artery. In conclusion, radial brachial approach combined with tibial approach is an alternative method for the treatment of femoral and popliteal lesion. Complications compared to the femoral approach are much less. In the future, it may move from any alternative method to the method of choice. Thank you.
very good result. Can I ask you how many of your tibial accesses are sheetless, and are there additional access or primary access?
Maybe more 20% primary access.
20% primary and 80% additional. You have proximal, femoral, brachial, or whatever.
Yes.
Okay. Thank you.
Still 20%, but I think that in the time it can be 50 or 40%.
How you decide to how you select patients for primary tibial access?
The patient with previous intervention, we have a date from the angio. We know how can proceed with radial access only for the angio, for the use the tibial approach, and after that, when we have the date for the patient and for the lesion, we take tibial approach for the primary approach.
And what is the usual size of sheet you use for primary tibial?
Only 5 French.
Okay.
And if the necessary to put the stent in the lesion, we use the Supera or Everflex. It's compatible with 5 French, yes. Supera sheetless. We use now, and for the iliac intervention tibial approach, in 5 patients this year.
Okay. Thank you.
Thank you.
Congrats for this. And my question is only angiographically targeting of the vessel, or
I take
ultrasound?
Only angio for the puncture.
Only. Okay.
And for the primary access?
When the patient has the calcium, we take the calcium for the visualization of the artery.
So the patient must have calcium for primary access?
Yes. For that, I told you we need the previous date for the use for the primary access. It's not indicate for all patients. You must have date for that. Okay, now we're going on the coffee break and waiting for the live case. We present on the live case second case of my presentation. Thank you.